Hi everybody, and welcome to our module on pulmonary embryology. The first thing you should know about the development of the lungs is that the lungs form as an outgrowth of the GI tract. The first structure to form in utero in terms of the lungs is called the lung bud. It's also called the respiratory diverticulum, and it is an outgrowth of the foregut, which is the future esophagus. If you look at this drawing on the screen, this is a drawing I go over in detail in the video on GI embryology. But for our purposes here, this is the foregut, the portion of the future GI tract up near the head, and there's this little bud coming off of it, and that is going to form the trachea and the lungs. And this all starts to happen in terms of the lung bud at about 4 weeks of development. Because the lung bud is an outgrowth of the foregut, which is the future esophagus, a septum needs to form to divide the trachea from the esophagus. But if that doesn't form normally, babies can be born with a tracheoesophageal fistula. This usually occurs together with another anomaly called esophageal atresia. The most common form of tracheoesophageal fistula with esophageal atresia is what's shown on the slide here. I talk about this in much greater detail in videos in the GI section, but the esophagus ends in a blind pouch like shown here, and the trachea has a fistula connecting it to the esophagus and the stomach. In babies born with this condition, the esophagus doesn't connect to the stomach, so accumulation of secretions will occur in the esophagus, and the baby will have drooling, choking, and vomiting. In addition, in these babies, you classically cannot pass an NG tube into the stomach. That's because the nasogastric tube cannot go beyond the blind pouch of the proximal esophagus. These babies also have a fistula connecting the trachea to the esophagus and the stomach, so that can allow air into the stomach, causing gastric distension and air that you can see on X-ray. You can also have stomach contents reflux into the trachea, causing aspiration pneumonia and respiratory distress in a newborn. And this entire situation is a result of abnormal formation of the septum between the lung bud and the foregut in the first few weeks of development. After 4 weeks, lung development is classically divided into 4 stages or periods. The first one's called the pseudoglandular, the second one's called the canalicular, the third one is the saccular, and the last one is the alveolar, and this actually occurs after birth. Your lungs are not completely formed at birth, they continue to develop during childhood and adolescence. So before we drill down on those 4 stages, let's briefly review a little bit of lung anatomy. So shown at the bottom right side of the screen is a drawing of the lungs, and this is the trachea, and it divides into 2 bronchi. And what makes a bronchi is the presence of hyaline cartilage. The bronchi then divide into secondary and tertiary bronchi and so forth, and eventually they form structures called bronchioles. And what makes a bronchiole is that there is no cartilage. This portion of the respiratory tract has an epithelial layer and some smooth muscle cells, but there is no cartilage. Bronchioles continue to branch until they form what are known as terminal bronchioles. These are the last bronchioles before you get into the respiratory bronchioles that lead to the alveoli. And then finally, as you may know, at the end of the bronchioles are the alveoli. These are the structures that have capillaries, and these are the structures that perform gas exchange. I've zoomed in on this picture just to make this more clear. We've got the trachea. It branches into primary bronchi, and then those branch down to become very small structures, bronchioles, which have no hyaline cartilage. And here's a zoomed-in picture of a couple of alveoli. This is a terminal bronchiole, which delivers air to the respiratory bronchioles. The respiratory bronchioles are what directly supply the alveoli, and then you have alveolar sacs out here at the end of the respiratory bronchioles. Okay, so now that we understand that, we can talk about the 4 phases of lung development. The first phase, as I told you before, is called the pseudoglandular phase. This occurs between 5 and 16 weeks in utero, and this phase gets its name because the lungs resemble a gland, therefore pseudoglandular. During this phase of lung development, the trachea and the bronchi are branching all the way down to the level of the terminal bronchioles. But there are no respiratory bronchioles or alveoli present yet. And so if you know this fact, then you can understand why babies born before 16 weeks cannot survive, because they don't have any alveoli yet, so they will never be able to breathe. Let's talk briefly about fetal respiration. This is breathing that occurs in utero. So as you may know, in utero, the baby's lungs are filled with amniotic fluid, but that doesn't mean the baby isn't trying to breathe. There are fetal breathing movements that occur in utero. Basically what happens is the baby aspirates amniotic fluid, and amniotic fluid fills whatever portions of the lung have developed. And this is important for stimulating further lung development. It's also important for growth of the respiratory muscles, and it's very important during the pseudoglandular phase. The baby needs to be swallowing amniotic fluid to fill up the lung that has developed so far, and that stimulates further growth into the more mature lung. And if you know this, it's easy to understand how mothers who are pregnant and develop oligohydramnios, which means decreased amniotic fluid, will have babies born with pulmonary hypoplasia. This is one of the elements of Potter's sequence, which I talk about in the renal embryology videos. And that's because if the baby's kidneys aren't normal, the kidneys of the baby in utero are what produce amniotic fluid. So that mother will have decreased amniotic fluid or oligohydramnios, and one of the consequences of that is that the lungs will fail to develop because during this pseudoglandular phase, the lungs need to be filled with amniotic fluid. Now let's talk about the next phase of lung development. That's the canalicular period. This occurs from 16 to 26 weeks in utero. During this period, the terminal bronchioles divide and start to form those respiratory bronchioles, and those bronchioles divide and start to form alveolar ducts. And at the end of this period, you're starting to get some alveolar structures, and survival after birth is possible. So basically, 26 weeks is about the earliest a baby can be born prematurely and survive, and that's because it takes this long for alveolar-type structures to develop so the baby can breathe. Other things that happen during the canalicular period are that the airway lumens become larger, and very important cells, the type 2 pneumocytes, form. These are the cells that produce surfactant, which I talk about in other pulmonary videos. What surfactant does is it lowers the surface tension to keep the alveoli open. The next phase is the saccular period. This occurs between 26 weeks of gestation and birth. During this period, the terminal sacs, which are primitive alveoli, begin to form. In addition, capillaries start to multiply in contact with the alveoli, so this is really preparing the baby for birth and preparing the lungs to be able to perform gas exchange. And the last period is the alveolar period. This period occurs generally after birth. It starts around the time of birth, maybe a few weeks before, and it continues throughout childhood and even adolescence. At birth, only about a third of the alveoli that you will ultimately have are present. After birth, during childhood and adolescence, there is an increase in the number of respiratory bronchioles and alveoli. So lung development is not complete at the time of birth. It continues all the way through the age of 10. Some sources say even through the ages of 15 to 20. During the alveolar phase, a process called alveolarization is occurring. So let's talk about what that means. In alveolarization, the air spaces are subdivided. New walls form called septa, and this septation divides up the alveoli that are present to make more alveoli. To understand this better, let's look at this picture on the screen. So in the top left corner is an image of what the lungs might look like at the time of birth, and you can see that there are these large air spaces. In the bottom right corner is what the lungs might look like after alveolarization. You can see that the large air spaces have been divided up into smaller air spaces, which are much more numerous. What this does is greatly increase the surface area for gas exchange. Even though the air spaces are smaller, there are so many of them that there's much more ability for gas exchange. And this is what's happening during alveolarization, which, as I said before, begins at birth and continues into childhood or adolescence. There's a clinical tie-in terms of alveolarization, and that has to do with the disorder bronchopulmonary dysplasia. This occurs in babies that are born prematurely. They're often treated in the NICU with things like surfactant, oxygen therapy, and mechanical ventilation. Although this keeps the baby alive, it also causes damage to the lungs. Oxygen can cause toxicity, and there can be lung trauma from the mechanical ventilator inflating the lungs. The result of this is that alveolarization after birth does not progress normally, so these babies, when they grow up, often have lots of respiratory problems during infancy. The good news is, because as we talked about before, alveolarization continues throughout childhood and into adolescence, these children often get better during the course of their childhood, because even though alveolarization did not occur normally when they were born, it does occur normally as they get older. So here's a drawing of how the lungs form. You can find similar drawings in your textbooks. First, the lungs begin at about 4 weeks. That's when that bud comes off the foregut, the future esophagus. The lungs then enter the pseudoglandular phase, where the bronchioles are formed, then the canalicular phase, where the respiratory bronchioles and the early alveolar sacs form. The saccular phase gets its name because that's where the alveolar ducts or sacs begin to form. And then alveolarization occurs after birth and into young adulthood, and that's where the alveoli continue to increase in number. If anything disrupts this process of lung development in utero, that leads to pulmonary hypoplasia, which means underdevelopment of the lungs. The first potential cause of pulmonary hypoplasia we've already discussed. That's oligohydramnios. That's when there isn't enough amniotic fluid for the baby to swallow and fill the lungs. And for this reason, pulmonary hypoplasia is one of the components of Potter's sequence, which I talk about in the renal embryology videos. The second reason a baby could develop pulmonary hypoplasia is if they have a congenital diaphragmatic hernia. This sometimes occurs in babies who have defective formation of a structure called the pleuroperitoneal membrane. Basically, these babies have a hole in the diaphragm and their abdominal organs herniate into the chest, and when this happens, this leads to underdevelopment of the lungs. This is often a fatal condition. If we go back to this slide, remember that the lungs bud off of the foregut, the future esophagus, and then they grow downward toward the abdomen. If there is a hole in the diaphragm and abdominal contents push up into the thorax, then the lungs won't be able to grow and develop. Moving on, let's talk about bronchogenic cysts. This is a congenital anomaly that is caused by abnormal budding of the foregut, and they're usually found in the mediastinum. And this should make sense to you because, as I told you before, the foregut, which is the future esophagus, gives off the respiratory bud, which goes on to develop the lungs. Well, sometimes there's another bud that comes off and doesn't grow any further, and that forms a bronchogenic cyst. So these are going to be found in the mediastinum, very close to the esophagus. They contain clear fluid in most cases, but if they develop infection, which can sometimes happen, you can sometimes see an air fluid level inside of the cyst. Some other details of bronchogenic cysts are shown on this slide. They do not communicate with lungs. As I just showed you, they bud off of the foregut and don't grow any further, so they will never have a connection to the future lungs that develop. They are lined by respiratory epithelium, which is columnar ciliated epithelium. Basically, they think they want to become the trachea and part of the respiratory tree, but that never happens. The walls contain cartilage. That's one of the diagnostic criteria if a bronchogenic cyst is removed surgically. They're usually asymptomatic. Radiologists find these all the time when someone has a chest scan for another reason, but in rare cases, they can become infected and lead to pneumonia, or if they're really large, they can compress the airway. Here's a picture of one right here. You can see it's in the center of the chest, beside the lungs, right behind the heart. It's right where you would expect it to be because it grows off of the esophagus. And here's a really big one that you can see on chest x-ray. You can see it here on the AP film, and you can see it here on the lateral film. As I told you before, this is something radiologists often pick up as an incidental finding. It's in the differential when someone has a lung mass and you're trying to work up whether it's benign or malignant. I'll finish with this slide and talk about pulmonary vascular resistance in utero and after birth. This is something that I talk about in great detail in the cardiac embryology videos because it has a lot to do with the changes in blood flow at birth. But here I want to point out a couple of tie-ins with pulmonary embryology. So in utero, the pulmonary vascular resistance in the baby is very high. One of the reasons for this is because, as we've just discussed, up and through the canalicular stage, there are few or no pulmonary capillaries. So obviously the resistance to blood flow through the lungs is going to be very high. In the later stages of development, even though the lungs may have formed, there's relative hypoxemia, and this causes pulmonary vasoconstriction. For example, let's give some numbers here. In the umbilical venous blood, the PaO2 is about 30 compared to 90 or 100 in someone with normal functioning lungs after birth. The O2 sat in utero is about 80% compared to about 99%, which is normal. So there is relative hypoxemia in utero, and that leads to pulmonary vasoconstriction. And because the pulmonary vascular resistance is so high, only about 10% of the cardiac output goes through the lungs in utero. The rest of it goes through shunts like the foramen ovale and others. After birth, the pulmonary vascular resistance falls significantly and the shunts close, and at this point, 100% of the cardiac output will go through the lungs in the baby, just as it does all through life. And I talk about this in much more detail in the cardiology videos on cardiac embryology. And that concludes our video on pulmonary embryology.